I would like to thank everybody for coming out tonight to learn about hip dysplasia in the adolescent and young adult. My name is Ying Li, and I'm one of the pediatric orthopedic surgeons at the University of Michigan CS Mott Children's Hospital. So before we get started, I thought I would just tell you a little bit about myself. I earned my undergraduate degree from Dartmouth College. Then I decided after 4 years in snowy rural New Hampshire that I would head south to North Carolina for a few years. I attended medical school at Wake Forest University and stayed at Wake Forest to complete my orthopedic surgery residency. I then headed back up north to Boston, where I completed my pediatric orthopedic surgery fellowship at Children's Hospital Boston. My clinical interests include hip disorders such as hip dysplasia, spinal deformity, including scoliosis, lower extremity disorders, and pediatric orthopedic trauma. I have many research interests. Some of my current projects are listed on this slide. These include management of early onset scoliosis and spondylolisthesis, pain control after pediatric spinal deformity surgery, correction of adolescent tibia vera with a talar spatial frame, and treatment of pediatric subtrochanteric femur fractures. Some other fun facts about me. I am a former ballerina. I lived in Iowa, Canada, New Hampshire, North Carolina, and Boston before moving to Michigan. I'm married to a bariatric surgeon who also works at University of Michigan, and I actually have hip dysplasia. So before we get started talking about hip dysplasia, I thought it would be useful to first go over some hip anatomy. So here is a drawing of the pelvis. This is the lumbar spine, and then here are your hip joints. So the hip is a ball and socket joint. The ball is the femoral head, and this is located at the top part of the thigh bone or femur. And the socket is the acetabulum, which is a part of the pelvis. Cartilage lines the acetabulum and also covers the femoral head. The hip is stabilized by muscles and tendons, some of which you see up here on the right, as well as ligaments, which you can see down here, and also the joint capsule. The labrum is a special type of cartilage that is located along the edge of the acetabulum, and this also helps stabilize the hip. So now that we understand some hip anatomy, we can talk about hip dysplasia. So developmental dysplasia of the hip, or DDH, is when the hip joint is the wrong shape. This is primarily a problem with the hip socket or acetabulum, and basically the acetabulum is shallow. So instead of being shaped like a cup, a dysplastic acetabulum is shaped more like a saucer. Hip dysplasia is a spectrum of disease. A shallow acetabulum can result in an unstable hip. So if you look at the hip here in figure A, this is a drawing of a normal hip. In figure B is a drawing of a hip with mild dysplasia. So the acetabulum is slightly shallow, but the femoral head is still located within the acetabulum. In figure C, we have an even more dysplastic hip. So an even more shallow acetabulum has actually led to subluxation or partial dislocation of the femoral head from the acetabulum. And then in D, which is the worst case, you have an even more shallow acetabulum, which has led to complete dislocation of the femoral head from the acetabulum. So how often does hip dysplasia occur? 1 out of 100 children are born with hip dysplasia or subluxation. 1 out of 1,000 children are born with a dislocated hip. And it's important to note that children with normal hips at birth can actually develop problems during the newborn and neonatal period. Who gets hip dysplasia? Females are more commonly affected. 80% of patients with hip dysplasia are female. The left hip is also more commonly affected, most likely secondary to the most common position of the baby inside the uterus. Breech positioning is a major risk factor. Being a firstborn baby is also a risk factor secondary to a tighter and unstretched uterus. And lastly, a positive family history is also a risk factor for hip dysplasia. So if you have one normal parent who has had a previous affected child, then there's a 6% risk that they'll have a subsequent affected child. If you have one affected parent who has no previously affected children, then there's a 12% risk that they'll have a subsequent child with hip dysplasia. And then if you have one affected parent with one previously affected child, then there's a 36% risk of having a subsequent child with hip dysplasia. Signs and symptoms of hip dysplasia. So hip dysplasia may be asymptomatic, especially if the dysplasia is mild. But the most common symptom is groin pain that worsens with activity. There may also be a limp, as well as catching, locking, and giving way of the hip. Remember that there are other conditions that can cause hip pain as well. These include trochanteric bursitis, snapping hip, which can be from snapping of the iliotibial band or the psoas tendon, femoral acetabular impingement, and also torn labrum. So it's important for your doctor to look for these other conditions when evaluating you with hip pain. Diagnosis of hip dysplasia is typically done with x-rays. There are many different x-ray views that we like to get. X-rays not only allow us to diagnose hip dysplasia, but it also allows us to determine the severity of the hip dysplasia. So one of the most common x-rays that we get is an AP pelvis x-ray. So this is a front view of the pelvis. We usually like to obtain this in a standing position. So again, just to go over some anatomy, this is your pelvis. This is the lumbar spine, so your low back. And then these are your hip joints here. One of the measurements that we like to do on the AP pelvis x-ray is called the lateral center edge angle. So this angle is measured by drawing a vertical line extending up from the center of the femoral head, and then a second line extending from the center of the femoral head to the edge of the acetabulum. And the angle formed by these two lines is called the lateral center edge angle. The normal angle should be 25 degrees or greater. So you can imagine that if you have hip dysplasia and you have a more shallow acetabulum that covers less of the femoral head, this angle will be smaller. And the smaller the angle, the more severe the dysplasia. So here's a real-life example. This is an AP pelvis x-ray of a patient with bilateral hip pain. You see the lateral center edge angles are drawn out for you. And his angle is only measured about 10 degrees. So he did have hip dysplasia, or he does have hip dysplasia. Another study that may be helpful for the diagnosis of hip dysplasia is called an MRA, or a magnetic resonance arthrogram. So this is an MRI that is performed with gadolinium, which is a contrast agent injected into the hip joint. And this study allows us to determine the condition of the cartilage in the labrum. So here's an example of an MRA. So this is your femoral head, and this is your acetabulum. And this arrow here is pointing to the labrum. So remember, the labrum is that special cartilage that is located along the edge of the acetabulum. And the MRA demonstrated that this patient had a tear in his labrum. So why can hip dysplasia be a problem? A shallow acetabulum cannot completely cover the femoral head, which can lead to hip instability and abnormal forces on the hip joint, which in turn can lead to abnormal wear of cartilage in the labrum and can cause the hip joint to wear out faster, meaning the development of arthritis. Hip dysplasia is actually one of the most common causes of arthritis in the young adult. So a helpful analogy to understand all of this is to compare the dysplastic hip to a tire that is out of alignment. So the cartilage wears out faster in a dysplastic hip, just like the tire treads wear out faster on a tire that is out of alignment. The more severe the hip dysplasia, the earlier the cartilage wears out. Once all the cartilage wears out, the hip needs to be replaced, but it can be difficult to predict when this will happen. Realigning the tire can prolong the life of the treads. Similarly, reorienting the acetabulum may prolong the life of the hip. Treatment options for hip dysplasia depend on the severity of the symptoms. So if there are no symptoms or minimal symptoms, then we recommend non-operative management, which consists of anti-inflammatory medications and activity modification, usually avoidance of high-impact activities. If there are persistent symptoms and severe limitation of activities, then we recommend operative management. The type of operative management depends on the condition of the cartilage in the hip joint. So if there is no significant cartilage wear, then the treatment of choice is hip preservation surgery. If there is significant cartilage wear, then hip replacement surgery is the best option. Today we're going to focus on hip preservation surgery. So the goal of hip preservation surgery, the main goal, is to decrease pain. We also hope to slow the development of arthritis by correcting the hip deformity and normalizing the forces on the hip joint. Hip preservation surgery is the preferred treatment in adolescents and young adults to delay the need for hip replacement as long as possible. The most popular hip preservation procedure is called the Bernese periacetabular osteotomy, or PAO. This procedure was initially described by Professor Reinhold Ganz in Bern, Switzerland in 1988. In this procedure, the acetabulum is reoriented to make it less shallow so it can cover the femoral head more completely. So this is a photo showing two of the common incisions that are made when performing a PAO. So just to orient you, the patient is laying on their back, and we are looking down on the front of the right hip joint. So the patient's head is over here, foot is over here, front is up here, and the back is here. And a common incision is a diagonal incision. We call it a bikini incision along the front of the hip. In patients who are bigger or more muscular, sometimes a curved vertical incision is made instead. On this next slide, I've rotated the photo so that it's like we're looking at the patient from the front in a standing position, and then put the photo of a patient who's actually had a PAO so you can see what a scar might look like. So in the PAO, 4 cuts are made in the bone around the acetabulum. So once again, this is your hip socket, and these are the 4 cuts that are made in the bone. The acetabulum is then reoriented so that it can cover the femoral head more completely. The acetabulum is then held in place in its new position with screws. There is some variation in terms of screw placement, so sometimes you won't see this screw here and you just see the vertical screws. So here's just another diagram. So again, this is your acetabulum. These are the 4 cuts that are made in the bone. Your acetabulum is then rotated, and then it's held in place in its new position with screws. So here are some real-life examples. So in the top left here is an AP pelvis x-ray of a patient with bilateral hip dysplasia. So you can see, I hope you can see, at least from where you're sitting, that both hips are only covered by the acetabulum by about 50%. And then here on the right is an AP pelvis x-ray after this patient has undergone a PAO on the right side. So you see now the ball of the hip is completely covered by the acetabulum. And then here's another example, again an AP pelvis x-ray of a patient with left hip dysplasia. So the femoral head is only about 50% covered by the acetabulum. And then here is an AP pelvis x-ray after they've undergone a PAO. And now the femoral head is completely covered by the acetabulum. So the typical postoperative course after a PAO is an inpatient hospitalization for 5 to 7 days. At the beginning of the procedure, we usually ask the anesthesiologist to place an epidural catheter for postoperative pain control. The epidural catheter is usually pulled on postoperative day number 2. We also typically place a surgical drain that is also removed on postoperative day 2. Patients are partial weight bearing after surgery, so they work with physical therapy before they get discharged. Patients over 16 years old are at higher risk for blood clots, so usually we send these patients home with a blood thinning medication for 3 to 4 weeks. Patients are partial weight bearing for usually 6 to 8 weeks, depending on the rate of healing of the bone cuts on follow-up x-rays. And then we proceed with screw removal at 6 to 12 months, which is an outpatient procedure. So the PAO is a complex procedure with risks. The most common complication is sciatic nerve dysfunction. This is usually a stretch injury to the sciatic nerve that recovers spontaneously. Other complications include vessel injury, infection, blood clots, and incomplete healing of the bone cuts. And lastly, the hip may still develop arthritis in the future, even if the procedure is successful. So how long will the hip last after a PAO? So on this slide are the results, or the combined results of two studies that looked at the intermediate to long-term results after a PAO. One of the studies was performed at Children's Hospital Boston, which is where I did some of my training. The other study was conducted by Dr. Ganz's group in Switzerland. As you may recall, he is the surgeon who came up with this procedure. In the left column are the number of years after the PAO, and in the right column is the survival rate of the hip, meaning the likelihood of not needing a hip replacement. So based on these two studies, 5 years after a PAO, there is a 96% survival rate of the hip. At 10 years after PAO, the survival rate goes down to 84%. And then at 20 years after a PAO, the survival rate of the hip is 61%. But still, if you think about these results, you may say 61%, is not a very good survival rate after 20 years. But, it's not ideal to do a total hip replacement in a 30-year-old with hip pain. So if it means that you can delay that procedure until they're 50 or maybe even 60, then that is still considered a good outcome. So who are the best candidates for a PAO? So before we go into that, I think it would be good for us to understand the term joint congruency. So joint congruency is how well the shape of the hip socket and the ball match. And it's a way for us to assess the thickness of the cartilage. So if you look at this diagram here, this hip has excellent joint congruency. The shape of the acetabulum and the femoral head are pretty similar. There's a nice thick joint space, which implies healthy, thick cartilage. Whereas if you look here, this is the diagram of a hip with poor joint congruency. The shape of the acetabulum and the femoral head do not match. There is thinning or even complete disappearance of the joint space, implying thin or maybe even completely eroded cartilage. So based on those two studies to which I referred to earlier, the best candidates for the PAO are people who are under 35 years old with excellent or good preoperative joint congruency and no or minimal preoperative arthritis. So in summary, hip dysplasia is when the hip joint is the wrong shape, the hip socket or acetabulum is too shallow. Hip dysplasia can be a cause of hip pain in adolescents and young adults, and it can cause the hip joint to wear out early. Patients who have no or mild symptoms can be treated non-operatively with anti-inflammatory medications and activity modification. If there are persistent symptoms with no significant cartilage wear, then hip preservation surgery is the treatment of choice. Again, hip preservation surgery involves reorienting the hip socket. The most common procedure is the periacetabular osteotomy, or PAO. And then if there are persistent symptoms with significant cartilage wear, then hip replacement surgery is the best treatment option. So if anybody wants to learn more about hip dysplasia, there are some good online resources. So the website for the International Hip Dysplasia Institute is at www.hipdysplasia.org. This website was actually started by Larry the Cable Guy. For those of you with kids, your kids will know him as the voice of Tow Mater from Disney's Cars. And he and his family became interested, well, Larry the Cable Guy, not Tow Mater. Larry the Cable Guy's family became interested in hip dysplasia because his son was actually born with hip dysplasia. And they realized how few online resources there were for patients and families. So that's how they came up with this institute and this website. And then in terms of local resources, there's the University of Michigan hip team. So I, as well as several of my providers, treat a wide variety of hip disorders. Between all of us, we provide a comprehensive care of the hip from the newborn to the elderly. We offer both hip preservation and hip replacement surgeries. And if you want to learn more about us, then please visit our website. And that's it. I guess I ended a little early. So does anybody have any questions? We have plenty of time.
What's the difference between MRA and MRI?
So an MRA is an MRI, except that you have contrast, which is injected into the hip joint. So this allows us to get a better look at the cartilage and some of the soft tissue structures inside the hip joint. So the A part stands for Arthrogram, which means the injection of the dye into the hip joint.
with arthritis, hip joint wear out?
Yes. Arthritis is when the cartilage lining of the hip joint wears out.
Thank you.
In terms of activity modification after you have the surgery, what are the recommendations? What sports can you do?
Oh, after the surgery? So once all of the bone cuts heal, we don't limit patients from doing the activities that they like to do. So, I mean, I don't think too many professional athletes have had this procedure done, so I can't say for sure that you'll be able to go back to professional sports like football or any extreme sports like skydiving or gymnastics. But in terms of even recreational athletes who are serious about their sports, they're able to get back to their previous activities after this procedure.
Okay, I have two questions. First, if you have a problem, you need a hip replacement, but you try to delay it until you get more old, you know? And if you are not covered by the insurance, what shall you do?
If you don't think that you'll be covered insurance when you will need the hip
First,
replacement?
I need to do it, but I'm delaying it until I can't stand the pain. This is one question. Is it good to delay it, or it's better to do it? Another thing.
So correct. So your insurance won't cover hip replacement at all? Huh. Okay. Well, I don't.
Any assistance from the?
Yeah. So at University of Michigan, we do have case managers who can help with all of that. So I mean, I don't know if University of Michigan is somewhere that your pediatrician or your PCP can refer you to. But we definitely have case managers who can assist with insurance issues. In terms of delaying the surgery, so I'm not a total joint replacement surgeon, but even the best total hips or total knees can only last maybe around 20 to 25 years. So of course, technology improves the longer you wait, but you know, and the longer you wait, then the less likely you may need a revision surgery. So that's one reason why we prefer not to do a total hip replacement in, say, a 30-year-old, because we know that by the age of 45 or 50, they'll need a repeat surgery to get another total hip. So, but even still, you know, women and, you know, people survive into their 80s and 90s now. So we don't want you to get a second surgery either. So the longer you can wait, you know, the better, because you may avoid needing a second surgery. I would say that this would be a decision that you have to make with your physician as well, because if on the x-rays you already have a lot of deformity of your femoral head and the acetabulum because of the arthritis, that deformity can get worse, and sometimes that can make the total hip replacement more challenging. So if you're, from a symptomatic standpoint, if you're able to wait, the longer you wait, then maybe you'll be able to avoid that second surgery. But that's a decision that you probably should make with one of your doctors as well, to make sure that waiting isn't going to make the surgery more difficult and higher risk.
And of course, you need somebody to help you, like inside the house.
So probably during the first couple of weeks at least, it would be a good idea to have somebody at home with you. You know, after a total hip replacement, you'll be full weight bearing on that leg. With a PAO, you'll be partial weight bearing, so it'll be a little bit more challenging to get around your house after a PAO. With a total hip replacement, you'll be full weight bearing. You may need a walker, but it'll be a little bit easier for you to get around your house. But still, during the first couple of weeks after surgery, we recommend that you should have somebody at home with you.
But if you don't have anybody, there is like a rehabilitation center the hospital can offer?
Yep. So usually the rehab process it requires some planning. So if you know in advance, before your surgery, that you won't have anybody at home to help you, then it's good to let your surgeon know that, so that he can get the case manager and the discharge planners involved to start looking for a rehab place for you. But usually, you know, after the surgery, we need to get a physical therapist and an occupational therapist to evaluate you and agree, yes, you do qualify for rehab. And then it's a matter of which rehab facilities your insurance will pay for, and also availability. So a lot of rehab facilities fill up really quickly, and it can be hard to get a bed.
So you have to arrange with both the hospital and the rehabilitation center.
Yeah, and the case manager, at least at University of Michigan, we're fortunate in that every department has a case manager, and we see these situations all the time. So if you know, again, just planning in advance. So if you know in advance that you won't have anybody at home, then just let your surgeon know so that the case managers and the discharge planners can get involved early. Okay. Yes?
What's the theory behind greater incidence for females and left hip?
So the thought is that females have a higher risk of, or a higher rate of hip dysplasia, partially because of ligamentous laxity. So females tend to be a little bit more loose jointed, if you will. So they're more likely to have some subluxation or even dislocation of the hip. That's one theory. In terms of the left hip, the most common position for the baby to be in the uterus is left occiput anterior, meaning the left side of their head is facing up. And in that position, the left hip is, for lack of a better word, sort of crammed against the lumbosacral spine, the lower spine in a female. And so the thought is that positioning of the left hip inside the uterus contributes to the dysplastic acetabulum, as well as some subluxation, so partial dislocation or even complete dislocation of the hip.
My daughter was diagnosed with bilateral hip dysplasia as a newborn. She's firstborn female as well.
Yeah.
And so after wearing the brace during her first year, her angles are normal now. So as she gets older, what's the likelihood of her developing issues, arthritis, and possibly needing a hip replacement?
So since her numbers are normal now, the odds of her having problems later on is pretty low. In the past, we used to say, oh, at your 2-year checkup, or maybe even after the harness comes off, if everything looks good, we just say, you know, see you later, you'll do fine. But now, many pediatric orthopedic surgeons will follow these patients until skeletal maturity. That's typically what I do in my practice, especially if one of the hips was actually dislocated, because you can... Right, so usually what I like to do is the femoral head usually is cartilage and doesn't turn into bone, meaning you can't see it on an x-ray until around 4 to 6 months. So that's why early on we do ultrasounds, which your daughter probably had at least 1 or 2, to monitor the hip and its development. And then usually after the femoral head has turned to bone and you can see it on the x-ray, then we use x-rays to monitor the condition of the hip. And we usually, you know, after the age of 2, we usually like to get x-rays every 2 to 3 years just to make sure that things are going well, because sometimes the acetabulum can not develop completely normally as kids grow. So that's why we like to follow them into a skeletal maturity.
And how long, at what age do you think that should be followed till?
So usually girls are considered skeletally mature at around the age of 14. So, or 1.5 to 2 years after the first period. So that's just a general rule of thumb. Everybody can be a little bit different. But that's probably the more prudent thing to do. And one front AP pelvis x-ray every 2 to 3 years is very little radiation and not a risk. So, yeah. Compared to missing late dysplasia and problems later on down the road, getting an x-ray every couple of years is not a big deal. Mm-hmm. Yes?
For those newborn baby, when you find out that dislocation, and even in the past, you used to use the so-called float position and just fixing that. Do you still use that now?
Yeah, so the Pelvic Harness, which is what she was talking about her daughter having, it's still the treatment of choice for babies under the age of 6 months with either hip dysplasia or subluxation, so the partial dislocation or complete dislocation of the hip. So of course not all babies can tolerate the harness, but the majority of babies can. And that is very successful at treating hip dysplasia, and most of the time is successful at treating subluxation and dislocation. But again, it's something that you have to follow closely. If in the Pelvic Harness it looks like the hip is not seated in the right position and things aren't improving, then you may need to change your management plan. But that's still, the Pelvic Harness is still something that we use in babies under the age of 6 months.
How long do they have to be in this position?
So it depends. A lot of it depends on how quickly their ultrasound parameters are improving, and also whether the hip looks like it's concentrically reduced. So if it's just hip dysplasia where the hip isn't dislocated, the acetabulum is just a little shallow, then usually, everybody's protocol is a little bit different, but I'll usually get an ultrasound every 2 to 3 weeks. And then once the acetabulum looks like it's normalized, then I'll wean the patient out of the harness.
So you will, the rim or acetabulum will grow and cover that?
So the thought is the pelvic harness that he's referring to basically keeps the legs in sort of a frog position. So the hips are flexed up to about 100 degrees and they're opened out to about 60 degrees. And so in that position, you're directing the femoral head, so the ball of the hip, into the acetabulum. So the ball of the hip is round, so the hope is by directing it into the acetabulum, it'll stimulate the shallow acetabulum to grow into a round position. So did I answer your question? Okay. Yes?
I had complete dislocation and I have a daughter. Should she be checked in any regular way?
So again, that's, everybody's protocol is a little bit different, but I would say many pediatric orthopedic surgeons at least would say that if you have a risk factor, which in this case would be positive family history, then it probably would be a good idea. I don't know how old your daughter is. If as a newborn an ultrasound is low risk, there's no radiation exposure, so. Yeah, so it probably would be worthwhile for her pediatrician just to get an AP pelvis x-ray because my guess is if she has a dislocation of the hip, we would know that by now because one leg would be shorter. Of course, if both hips are involved, that may not get picked up because both legs will be shorter, but they'll be the same length. But subtle dysplasia where the acetabulum is just a little bit shallow won't necessarily get picked up. So it probably would be a good idea just to get an AP pelvis x-ray to make sure.
Aren't there any medication we can take to avoid the hip preservation or hip replacement?
So usually, for orthopedic surgeons, our pain medication of choice is anti-inflammatories. So Motrin or naproxen.
This is only to reduce the pain, that's all.
Yeah, so that can help.
Other medication that give you strong for the...
There's no medication. Yeah, there's no medication that can regrow the cartilage. Probably at every institution, every bone and cartilage lab, somebody's trying to figure out how to regrow cartilage. So if you can figure it out, you'll be a billionaire.
We don't want surgeries.
Yeah, well, I would recommend anti-inflammatory medication because there are less side effects. Of course, if you have a history of, stomach problems, ulcers, that kind of stuff, you should talk to your PCP first before starting those medications. But those are the standard medications that we start patients on if they're having pain. So.
Actually, what about Prolotherapy, which, as I understand it, is injection of a saline or a dextrose solution, which is supposed to not regrow the cartilage, but I guess, I'm not entirely sure, but it's supposed to sort of add cushion back in.
Yeah, so again, I'm a pediatric orthopedic surgeon, so we don't use some of those compounds. I guess Synvisc is probably maybe what you're referring to. Basically, it's something that can be injected. I think it's only FDA approved to be injected into the knee joint, but it's probably used in other joints as well. But sometimes people with early arthritis, you can inject that into the knee joint. It's usually a series of 3 injections done weekly, and that is thought to increase the lubrication of the knee joint and potentially provide some symptomatic relief. Since it's not something that I use on kids, I don't know what the long-term outcome studies are. My guess is it just provides symptomatic relief, but it doesn't really delay the progression of the arthritis. I mean, with arthritis, too, it's not just a radiographic diagnosis. Some people have complete loss of joint space, a lot of bone spurs. If you look at their x-ray, your hips or your knees start hurting, but they may have no symptoms. And there can be a patient whose x-rays don't really look that bad. You would consider them having mild arthritis, but they may have really severe symptoms. So you can't just decide on treatment based on the x-rays. So, yes?
I have a question. So when adults reach 65, because I have a friend, she's 75, 10 years ago she had a hip replacement. Another friend, she just had a hip replacement around close to 70. So when adults have a hip problem, it's nothing to do with this kind of disorder?
So they may have a history of hip dysplasia that was just never diagnosed. There are definitely studies, the more that we learn about hip dysplasia and some of these other hip entities like femoral acetabular impingement, the more we realize that quote-unquote idiopathic arthritis, so arthritis that just happens for no good reason that we know, that's actually fairly rare. So the more that we learn about all these complex hip problems, the better we are at analyzing x-rays of patients who've developed arthritis and try to figure out if there was something structurally abnormal about their hip joint that wasn't picked up when they were younger, which caused them to develop the arthritis. So there's definitely a possibility if we could look back and get x-rays of your friend's hips when they were younger, before the onset of the arthritis, that maybe there was something a little bit structurally abnormal about their hip that made them more prone to developing arthritis later on.
So should we go to check with our doctors?
Well, I'm not proposing that everybody go out and get hip x-rays, but we're just learning more and more about hip problems and what can lead to arthritis and problems down the road. So.
How many percent of those newborns in university hospital miss that part and then discover later, 1 year or 2 years?
I don't know the exact percent, but usually subluxed or dislocated hips that are missed do get referred to the big academic medical centers. So probably the percentage of diagnoses of late dislocated hips would be higher at an academic center just because we get referred a lot of patients from elsewhere. But I don't know what the exact percentage is. I would say, though, with breech positioning being probably the most serious risk factor for hip dysplasia, that the AAP, the American Academy of Pediatrics, actually recommends that all breech babies get a hip ultrasound. And usually it's best to get the hip ultrasound at the age of about 6 weeks, because before the age of 6 weeks, the hips can still be a little bit immature. So it'll look like the acetabulum is a little bit shallow, but it turns out the hips are just immature and will develop normally on their own. So most pediatricians, unless there's something concerning about the exam, but if it's just a screening for ultrasound for a breech baby, they'll wait until around the age of 6 weeks.
Is that a routine procedure?
The ultrasound?
Yeah.
I would say it's fairly routine. I would say that most pediatricians do get a screening ultrasound in breech babies. So if on the exam, on the newborn exam, if there's something about the hip, like a click or a clunk or some asymmetry between the hips that would make the pediatrician more concerned, then usually they're not going to wait to get the ultrasound. But if it's just a screening ultrasound in a breech baby, knowing that breech positioning is a big risk factor for hip dysplasia, then usually the pediatrician will wait until around the age of 6 weeks when the hip's a little bit more mature. And that's just so we don't treat more babies with a pelvic harness than is necessary. So.
Yes, for the older patients, are there any benefits for glucosamines, use of glucosamines or chondroids?
So again, I'm a pediatric orthopedic surgeon, so I don't prescribe that. I don't know that there's very good data on those compounds. And the main reason, I think, is because a lot of those supplements aren't really FDA regulated. So depending on the brand that you buy, there may be more or less, or maybe even none of what you think is actually in there. So I just think that it's been difficult to do good studies looking at the effectiveness of those compounds. But in my training, when I worked with the total joint surgeons, usually what they would say is if you're not having any side effects from those medicines and you feel like it's providing you with some symptomatic relief, then just go ahead and continue taking it. But I just don't think there's very good data on those compounds, mainly just because of poor FDA regulation and not knowing exactly how the percentage of glucosamine and chondroitin is actually in what people are taking. So.
What's the situation with regard to plastics?
To what?
Plastic substituting
to plastic substances. So I'm not sure that I know of any studies looking at that. Do you know of some?
No. I was just wondering.
You could become rich too, just like you, if you learn how to regrow cartilage. Any other questions? No? All right. So thank you very much for coming on a school night. And if you want any more information, there are some handouts, and also there's some information about our next talk.